Good afternoon, ladies and gentlemen. Good afternoon. Better. Good afternoon. All right. You haven't had your coffee yet. We'll do that after this presentation. Before we get started, can we have a round of applause for our AV team that's making all of this possible? You don't see them, but they help make all of this happen, and they make me look good, so I appreciate it. So, our next presentation this afternoon is our plenary discussion on substance use and pain management. And joining us on the stage today will be three distinguished gentlemen. First, Dan Kruger is a professional motorcycle racer with multiple national championships. He has a 30-plus year addiction to opioids and utilized the MORE program to not only 100% end his opioid use, but also reduce his chronic pain. It is an incredible testament to the program and a special story that needs to be heard. Now, following Dan is Dr. Sanjay Gupta, an award-winning neurosurgeon and CNN's chief medical correspondent, where he has spent more than 2 decades reporting on critical health issues around the world. A practicing physician and professor of neurosurgery at Emory University, he has been a trusted voice on major public health challenges, including the COVID-19 pandemic. A best-selling author and member of the National Academy of Medicine, Dr. Gupta is widely recognized for translating complex medical science into accessible, actionable insights for millions of people. And then also joining us on the stage will be Dr. Eric Garland, an endowed professor at the University of California, San Diego, and a leading researcher in addiction science and mental health. A licensed clinical social worker and neuroscientist, he is the developer of mindfulness-oriented recovery enhancement, or MORE, an evidence-based therapy that integrates mindfulness and neuroscience to treat addiction, chronic pain, and emotional distress. Through his research, clinical work, and national leadership, Dr. Garland has advanced innovative, science-driven approaches to improving recovery outcomes and addressing the opioid crisis. Ladies and gentlemen, let's welcome them all to the stage.
Thank you, Doug. Well, good to see you all out here. Thank you for spending your afternoon with us. My name is Eric Garland, and I'm a professor at UC San Diego in the Department of Psychiatry and the Sanford Institute for Empathy and Compassion. And today I have the honor of speaking with you about my life's work. So we all know that pain helped to drive the opioid crisis. When we hurt, physically, emotionally, spiritually, it's easy to reach for anything that promises relief. But pain and addiction rewire the brain's reward system, robbing us of the ability to experience natural, healthy pleasure, joy, and meaning in life. And so we get stuck in a trap, taking higher and higher doses of the drug just to fill the emptiness inside. But that only digs the hole even deeper. If we don't treat the roots of this problem, the vicious cycle will continue. But there are new and powerful tools that can help alleviate suffering and turn the tide of this epidemic, and that's why I'm here speaking with you today. When I was invited back to the RX Summit this year, I had a strong sense of deja vu. Last year, I stood on the stage and presented the science behind a therapy that I spent the last 2 decades developing. And the science is overwhelming. But what good is life-changing science if it never makes it into the field? You see, I come from the world of academia, where research is king. I've spent the last 20 years developing new treatments for addiction, opioids in particular, and chronic pain, because these two often go hand in hand. It was an epidemic of unrelieved physical and emotional pain that helped to drive the opioid crisis. And to meet this challenge, I developed mindfulness-oriented recovery enhancement, or MORE, which has been hailed as one of the greatest breakthroughs in behavioral treatment in the past 30 years. And we've tested it relentlessly, 16 randomized controlled trials, over 40 peer-reviewed scientific manuscripts, over $90 million in federal research funding. MORE is an evidence-based, neuroscience-informed therapy that uses a unique and targeted treatment sequence to simultaneously address addiction, emotional distress, and chronic pain. MORE can be delivered in groups or individually, face-to-face or through telehealth, over 4 to 8 weeks. It's insurance reimbursable, and once somebody learns it, they can keep it for life. It's really been an amazing journey. I've used EEGs and functional MRIs to understand how and why MORE works. And it works. It works for addiction. It works for pain. It works for PTSD, emotional distress, and depression. And I'm not just talking about symptom level changes here. MORE actually helps the brain heal from pain and addiction. In fact, the brains of people treated with MORE start to look more like the brains of people who never had addiction in the first place. MORE helps to reverse the effects of addiction and pain on the brain's reward system by teaching people how to reclaim a natural, healthy sense of pleasure, joy, and meaning in life. And who couldn't use more of that? Let's take a look at some of the numbers. In NIH-funded clinical trials published in the Journal of the American Medical Association, adding MORE to standard MOUD care, some people call that medication-assisted treatment, reduced addiction treatment dropout by 59% and reduced drug relapse by 42% more than standard MOUD care alone. MORE therapy is 3 times more effective than standard group therapy at reducing opioid misuse. And MORE decreases chronic pain by an average of 25%, with effects lasting 9 months after the end of the 8-week therapy. Now, 25% is about as much pain relief as you'd expect to get from a dose of OxyContin. But here, we're teaching people how to use the power of their own mind to alleviate pain. And I want to point out that MORE isn't just useful for improving outcomes in medication-assisted treatment, but MORE strengthens clinical care across a wide array of treatment settings, including outpatient treatment, residential treatment, telehealth environments, primary care, and pain medicine, among others. Simply put, MORE has the strongest evidence base of any therapy for co-occurring addiction, emotional distress, and chronic pain. We've now trained over 1,000 people from around the world, and MORE is being used at some of our most prestigious healthcare institutions in this country. But given the enormity of the opioid crisis, we can and must do more. Research on the applications of MORE will continue, but at this point in my life, my mission is unmistakably clear. My goal is to vastly impact and alleviate the immense suffering caused by the opioid crisis by making the evidence-based MORE therapy program a central part of the standard of addictions care in this country. And that mission, that's consistent with why we're all here today, right? We're all here because we're responsible for accelerating solutions to the opioid crisis. Therapists, counselors, treatment centers, healthcare professionals and organizations, state and federal leaders, it's our task to impact this crisis. The people that we serve need innovative interventions that can restore dignity, hope, and the possibility of recovery. They need more. So let me give you an example of how this would work. And let's think big here, because the problems that we're facing in this country with pain and addiction are big, and so are the opportunities. You guys are an influential group of people. Okay, so let's take 10,000 patients who are under MOUD care. MOUD, or medication-assisted treatment, is the current gold standard treatment for opioid use disorder today. Data suggests that MOUD costs about $8,000 per patient each year. So to treat 10,000 patients, that's $80 million. Big and real. But the other big reality we all face is that 50% of patients drop out of MOUD treatment each year. And unrelieved physical pain and unrelieved emotional suffering are strong predictors of addiction treatment dropout and relapse. And that dropout is expensive. Conservatively, it costs $20,000 for every patient who drops out in terms of emergency room visits, hospital stays, criminal justice involvement. So if we have 10,000 patients and half of them drop out, that costs society $100 million a year, and it costs us tragically in lives and human suffering. Okay, but here's where I get excited. What if we treated all 10,000 of those patients with more? It's absolutely feasible. It's not hard. It wouldn't take more than a few organizations in this room to train 250 counselors, social workers, peer specialists, really anybody in the field. It's called workforce training, and the workforce is already in place. And we have an online training platform that makes training and more easy. Now, conservatively, each one of those providers could treat 40 patients in a year. So with 250 trained more providers, we reach all 10,000 patients. Okay, so now we have 10,000 patients undergoing standard MOUD care, but they're also receiving 8 sessions of more therapy alongside the meds. Now let's apply the results from the study in the Journal of the American Medical Association. And we reduce addiction treatment dropout by 59%. That's 2,950 lives saved. And that saves society $59 million. That's a huge impact. And more does have huge real-world impacts. In fact, we have some new data showing that more reduces emergency room visits by 73%. And so it's not surprising then that more is hugely cost-effective. In a recent economic analysis, it was found that for every $1 spent on more, there are over $700 in estimated cost savings. And the lifetime economic impact of more is estimated to be more than $300,000 per person. And this isn't just about dollars, right? This is about lives. And it means that delivering more therapy will keep many, many thousands of more people staying in treatment so that they can have time to heal. So in conclusion, backed by 20 years of rigorous results, more is powerful, brief, accessible, replicable, and affordable. It strengthens existing clinical care, and it fits seamlessly in a wide array of treatment settings. And at the end of the day, this is about lives saved. And for a modest investment in the addiction treatment workforce, we can save many, many more. Integrating more into the workforce will help those of us who seek to alleviate suffering by decreasing craving, relapse, and pain, and strengthening meaning, purpose, and joy. And I'd just like to take a moment now to ask you to contemplate your higher purpose. What motivated you to commit yourself to this line of work to begin with? No, seriously, it's important. Take a moment to reflect on that intention in your heart. Together, we can turn the tide of the opioid crisis. Not someday, but now, by putting more into the hands of the patients who need it and into the hands of clinicians like you who can deliver it with skill, hope, and unwavering compassion. Thank you very much. And if you're interested in learning about more, go to moretherapy.com or come to our booth in the exhibition hall, booth 420, to learn about more. But now I'd like to introduce 2 remarkable speakers. Dr. Sanjay Gupta, internationally acclaimed journalist from CNN and a renowned neurosurgeon. Sanjay's dedicated his whole career to educating the public, educating all of us about the importance of health and healing. And in addition to being just a brilliant human being and the best interviewer that I've ever encountered, he also has a really big heart. He's a truly compassionate person. And I'd like to introduce Dan Kruger, international champion motorcycle athlete, who was able to come off of using opioids after 30 years of using them through the MORE program. Dan contacted me around 2021 looking for help coming off of opioids. And after 30 years of using them due to a lifetime of accidents, injuries, high-impact trauma due to intense motorcycle racing, Dan was able to apply the skills he learned in MORE to completely stop his opioid use. And Dan is a hero on multiple levels. He's one of my personal heroes, but you won't find a person with a kinder heart. And So when Dr. Gupta found out about our work, he decided to cover it in his new best-selling book, It Doesn't Have to Hurt. He also decided to cover it on a CNN special documentary. And so the plan was for Sanjay to come to my lab at San Diego to learn about the neuroscience behind how we can use mindfulness to alleviate pain. My plan was to use an experimental pain testing procedure that we use in my lab, where we take a hot metal probe and we stick it against the patient's arm. The night before Sanjay arrived, I was in a full-blown panic. I called a CNN producer and asked, "Tell me, does Sanjay know how to practice mindfulness?" I'll never forget what she told me. She said, "Well, I don't know, but whatever you do, don't burn the surgeon." I think I needed mindfulness more than anybody else in the world in that moment. I was freaking out. Can you imagine being the guy who burns the world's most famous neurosurgeon? Fortunately, Sanjay is a rock star at everything he does, including mindfulness, so it all worked out fine. But now I'm going to have a conversation with both of these gentlemen about rethinking chronic pain and the opioid crisis.
I didn't know that part.
So I have my first question for you to build on that. Did I burn you?
You did not. I didn't know that story. I didn't know the backstory. Well, there's so much to talk about. And let me just say, first of all, I'm delighted to be here, back here. This is my second time at this summit, and with two guys who've become friends. We've really bonded over this issue and had a lot of, I think, really important conversations over the past year. So thank you. Thank you for that. I got to say, when I came to your lab, I did not know what to expect, and there's so much to sort of describe here, but one of the things that really struck me was that there's this experiment where you are using these 5 pulses of heat, and it's hot. It's the kind of heat that you would definitely pull your hand back from, you'd withdraw from. And you did it. You were measuring my pain levels and my unpleasantness levels, and then I went through the more training, and I did it again. 5 pulses the first time. After I went through the more training, I did not feel that 5th pulse, which was pretty remarkable. I mean, again, this is the kind of heat that you would actually pull your... And I think it was the first time, Eric, that I really started thinking about the idea that in a relatively short time, I was able to objectively change my brain in a way to not feel either as much pain or the unpleasantness associated with that pain. And I think in many ways, I think it's what started our journey.
Absolutely.
Yeah.
Absolutely. And that is amazing. And I would imagine as a neurosurgeon who really understands the circuits in the brain that control pain, amazing to see the power that the mind could have over pain.
Yep. And in acute pain, in a very sort of short-term sort of setting. But obviously we talked a lot about chronic pain as well. And I think this is one of the things that I think I've really been sort of deliberating over for some time. This idea that we think about acute pain and chronic pain, and they both have the word pain in them, but in some ways they are such fundamentally different things in the brain. We know acute pain, there's certain pretty reproducible circuits in the brain that get activated. When someone has an injury, you have these pain receptors, they send those receptors to the spinal cord, go up to the brain, and you see a sort of pretty defined sort of pattern in the brain. With chronic pain, it was sort of unbelievable to look at some of those images with you, but it's not just the pain circuits, it's the memory circuits, it's the emotional circuits. And I remember thinking almost when I was writing the book that I wish chronic pain and acute pain had totally different names because they are such fundamentally different things. And as someone said to me with chronic pain, and Dan knows this better than both of us, but they said it's a memory that cannot be extinguished. It just keeps getting played on a loop over and over again in the brain, which again I thought was so interesting and in an inspiring way, because I think that offers up a bunch of different opportunities potentially to try and treat it.
Absolutely. And so I was going to ask you, what since you're someone who's covered the opioid crisis for many years, what do you think people misunderstand about chronic pain and its relationship to the opioid crisis that we're facing?
Well, first of all, chronic pain is complicated. I mean, maybe this goes without saying for this audience, but I think we are probably talking about one of the most mysterious human sensations out there, one that is very hard to quantify, very hard to objectify. We still resort to, smiley faces and things like that when it comes to this, despite the fact that we're a country that spends $4.5 trillion on healthcare, 20% of our population is in chronic pain, and we still have some pretty archaic ways of even getting to a baseline in terms of what we're really talking about, quantifying it in some way. But I think, the opioid crisis, for me personally in my life, it's interesting, as a doctor and as a reporter, it is sort of overlapped. We're talking mid to late 1990s when this really started to take off, and it's ongoing. And it's gone through all these various phases. We've seen the heroin epidemic that's come out of it again. We've seen illicit fentanyl. We see all these things. But this core issue of pain still sort of fueling this in some ways, I think is something that we absolutely need to be paying attention to. It is still, I think, untreated pain in many ways, or undertreated pain that is still driving this. One of the examples I give sometimes to give context in a way that maybe people haven't thought about, we know the devastating toll opioids have taken. For some people, they can be a lifeline. There's no question. But we've seen addiction, we've seen the overdose deaths, we've seen all that. But in the scientific world, there's another issue as well, which is that the opioids kind of sucked up all the oxygen in the room. There was not a new pain medication, FDA-approved pain medication, since 1998, quarter century.
Wow.
Not 20% of the population deals with chronic pain, and to give context, there's usually about 50 to 60 new drugs approved every year by the FDA. So for one of the biggest chronic problems in America, not a single new drug until this past year, which was suzetrigine, the first new drug that was approved in a long time. That is something really worth considering. We know, again, the impact opioids had on our society. But in the scientific world, when something takes up that much attention, everything else becomes sort of secondary in comparison to that. Nothing else will be as good as opioids. I just want the opioids. Opioids are the gold standard. And yet, not only had there not been new therapies, existing therapies started to get minimized as well. So, when I wrote the book, I visited these emergency rooms around the country that are called opioid-sparing emergency rooms. They hardly ever use opioids. You come in with a broken hip, you come in with a migraine, whatever it may be, you're not likely to get opioids. But what are you getting? Things that have been around for a long time. Ketamine therapy, for example. Nerve blocks, which, that's a procedure, can take a little bit of time to do, but can be wildly effective and maybe prevent someone from ever needing opioids. Virtual reality. There were all these modalities that have existed for some time that got minimized in addition to not having any new FDA-approved drugs in more than a quarter century.
I think mindfulness probably fits in that category of overlooked therapies too. And that's incredible when you think about it out in the audience, 20%, right? So that's 1 out of every 5 people. So just look around you at 4 other people, and one of the 5 of you is going to have chronic pain. And then think about it in terms of the patients you treat, whether it's outpatient or residential treatment or medication-assisted treatment. That means a lot of those folks there are suffering from pain. And is their pain being treated effectively? And if it's not being treated effectively, then what you have here is one of the biggest relapse risk factors that's being unaddressed. Both physical pain and the emotional pain that comes along with it. And that's why I think it's really incumbent upon us in working with folks in recovery to address the physical and the emotional pain that drove the addiction in the first place.
But to Dr. Gupta's point, in the last 3.5 years since I've been off opioids, I've continued racing motorcycles. I've had several pretty bad accidents. A couple of years ago, I broke a collarbone and 4 ribs, punctured a lung. Went in, I was unconscious, went in, woke up in ICU, and the very first thing I said was no opioids. And the emergency surgeon at the time was telling me, we're gonna have to treat the pain. You're gonna need some pain relief. And he offered ketamine. And I said, is that not an opioid? I wasn't familiar at the time. And he said, no, you'll be fine. So I used ketamine for the immediate pain that I was going through. They did surgery on my shoulder, plated it, and I recovered without opioids, utilizing the MORE program, a little bit of Advil. Shortly after that, another year, maybe I broke my tibia fibia, plated it, no opioids at all. And more recently had some knee surgery, same thing, no opioids, just MORE program, normal physio, that type of thing. But now my body it understands that if it faces some traumatic situation, some pain, it's not a go-to, the opioids. I go to MORE program, I go to just personal rehab and just time and normal things like eating healthy and all the things that, more common sense. But I'm living proof that it's absolutely possible to still live what some might say a reckless life, but a more adventurous kind of career and not use opioids as a crutch or an excuse.
Thanks for bringing that up, Dan. And one of the questions I had for you was, what happened in your life that brought you to the moment that you decided you wanted to change your opioid use and come off of it?
Well, I've had addiction struggles since very young age, probably 12 years old. I didn't know at that point it was an addiction issue, but I started experimenting with drugs and alcohol. And through the course of time, as I matured and understood things a little bit more about life, I realized that I wanted to be better than that and step outside some of those things. And so kind of step by step, I weaned myself off of various things. I had a very serious drug overdose when I was 30, and that was the end of illicit drugs for me. Early 40s, I realized that I was drinking too much. I quit drinking. And the opioid stuck with me until about 3.5 years ago. And to answer your question, I just realized I knew already that they weren't helping because I was in pain, first of all. Second of all, I was getting bad migraines. I went through some diverticulitis and had surgery there. And, it can be questioned or argued if that was part of the cause, was my extreme use of opioids for so many years. And also, I'm a very calm person, even through difficult times. And I found myself more emotional. I would fly off the handle a little bit. And the bottom line is my wife, Holly, she was like, she never really said much about any of my decisions through life. But even she was like, I'm not sure if you should still be on these opioids. And I realized, okay, now it's time for the final step and to stop using opioids. And, without going through the whole story again of how we met and everything else, the bottom line is 6 or 7 months after we met, I was no longer taking opioids, wanting them or needing them. And then realizing in the following few years, I wasn't needing them at all. In fact, my chronic pain went down a little bit, my migraines went away, and the clarity came back, and things just kept getting better and continue to get better.
That's amazing. That's amazing. And what was it that you learned in the MORE therapy program that you found most helpful? Can you describe some of what made an impact on you?
For me, I've always been very big into training, personal health, and I realized, for me, I crossed it over to just training my brain. Instead of just training my muscles or my endurance, I realized that the way I'm wired is repetition, routine really helps me. And I just kept saying, it's time I got to go to the gym. Well, now it's time to work on myself with the MORE program and work on my brain. And then over time, it just became a normal thing. The nice thing about the MORE program, as opposed to my regular gym workout, which had a singular goal of just being healthy and having more endurance was I was getting additional benefits from the MORE program. Fortunately, I didn't have a lot of desire to continue taking opioids, so that wasn't one of my personal challenges. But with the chronic pain, with the migraines, and with just even some of the acute pain, to be honest, the MORE program had really helped me. But in addition to that, I was like re-energized. So I typically like to do work with the MORE program midday when I'm kind of a little bit stressed out, some anxiety, and it kind of gives me another bump for it'd be like having a couple of coffees or an espresso. It just gives me another burst of energy, positive energy, that gets me through the rest of the day. If I can just say one thing which happened to me only a few months ago, which was very interesting for me, was I was at the airport ready to travel. Something I don't talk about a lot is, because it's simply not that interesting, is I have arrhythmia. And it's manageable, but it comes back every 3, 4, 5 weeks. I get a bout of arrhythmia, and I have a way to manage it successfully. Well, I was at the airport getting ready to board a plane, and I got arrhythmia. And even though I know now from all the good medical doctors in my world that I have literally nothing to worry about, you can't help but worry when you can see your chest moving and you're short of breath and all these things. And then that anxiety creates a bit of panic when the thing just snowballs. Anyways, I'm sitting there going, okay, my normal way of getting rid of it isn't working. I don't know if I should board the flight. I don't know if I want to be in the air, just in case this one time it's different than the other times. And I was really contemplating if I was going to miss the flight. The flight had boarded, but they said there was still about 10 minutes left. And out of desperation, I just said, I'm just going to meditate and work on the MORE program. And I sat there, put my noise-canceling headphones on in front of the airport, and I just went through 7 or 8 minutes of the first 7 or 8 minutes of the therapy. And I was very lucky that I went deep into a meditative state, and I kid you not, my arrhythmia went away, and I boarded the plane. And the next day, I called Eric and I said, you won't believe it, I actually used it to stop my arrhythmia. So I said, you should add that on some of your sales material, because it gives me another tool to work with when I'm dealing with various different things. So it's more than just dealing with chronic pain, I guess, is what I wanted to say.
Thank you. Thank you. Yeah, and that story is completely amazing. And like I told you, Dan's a hero and an amazing human being. And I think he applied the same level of discipline that he applies to physical training. He applied that same level of discipline to the mental training through mindfulness practice in the MORE program. And you can see it paid huge dividends. But I think it makes sense from what we understand about the connection between the brain and the body, which is a real physical, hardwired connection, why changing the way your mind functions could change the way your brain functions, and then that could have a dramatic effect on sensations in the body, not only sensations of physical distress, like you're talking the arrhythmia, but also pain, and with respect to the focus that you all have, also reducing craving, which is essentially an embodied experience, and we know that's a big driver of relapse in people who use opioids. So it is really pretty incredible. And in fact, we have some new data showing that when patients go through 8 sessions of MORE, that because of the mental training process that the patients go through, that they can actually increase the thickness of their prefrontal cortex. They're actually growing their brain structurally, and that the more they practice the mindfulness, reappraisal, and savoring skills that are such an important part of MORE, the thicker the prefrontal cortex grows. And as the cortex grows thicker, that actually gives patients the ability to consciously decrease and regulate their craving, which is just a huge asset to addictions treatment. But I wanted to raise a question for Dr. Gupta and just for the panel for us to discuss, which is, If we were going to redesign pain care in America, what would that look like?
Well, first of all, I think there is a desire for this data that you're talking about in order to get to the point where people are going to adopt new strategies. And I've been a sort of lifelong meditator, my entire adult life at least. And I think as a neurosurgeon, a lot of times I'd get funny looks and stuff when I talk about meditation to my neurosurgery colleagues. And often, you'd sort of hear some version of, well, what's the proof? What's the evidence behind this? And so I think part of the reason I came to you initially was to basically collect some of that data from you, because I think it's understandably important. There's a lot of people out there who do this, like Dan. For them, it clearly works. But then to be able to collect larger data sets and present them and show the changes objectively that are happening in the brain, I think these things are important and probably the first step towards building the type of future pain care clinic that you're talking about. But one of the things, Eric, I think, again, because of opioids, we became sort of very reductionist about pain. As complicated as it is, we thought we could take a single pill and basically try and address all these various things that we've been talking about for some time. And I think we always probably knew that wasn't going to be a permanent sort of solution to it, but it was an effective Band-Aid for a period of time. What I think the future looks like is a combination not only of these various pain modalities that we're talking about, but also psychology, really understanding the impact of pain and things like that on the mind and how you can change it. I think that the idea, according to your data, that a single more session could be equivalent to 5 milligrams of OxyContin. That was kind of a remarkable statement to me. We don't expect OxyContin to be a permanent solution, but we know it can alleviate pain for a period of time. When I talked to Dan about this, somebody who's had chronic pain, and he says during the time that he's actually engaged in the protocol, he has no pain. It's a pretty remarkable thing, again, for 50 million people who never have the luxury of not having periods of time in their day where they don't have pain. That's the sort of thing that I think I would incorporate as well. To call it a multimodal, sort of, multidisciplinary clinic, I think might be shortchanging it a bit. But I think the future pain clinics, the future pain sort of therapies address both the body and the brain. If the brain doesn't decide you have pain, then you don't have pain. And I know sometimes that is a controversial thing to say, because people interpret that as saying pain is in your head. Nobody's saying that, but we are saying that pain is in the brain. And the brain can even make pain. I mean, phantom limb pain. The limb is not even there anymore, and yet it still hurts. Why would that be? Because the brain can take away pain and it can create pain. And I think unless the future of pain therapy addresses both, you're not going to have the kind of successes that we're talking about.
Very well said. Very well said. Dan, what do you think about if you were to envision a future pain care that does it right? And you and I have had conversations about this, about some of the healthcare people that you encountered along your way and how they did or did not advise you. And so if you were to do it right, what should we do?
Well, I think just from my experience, because I'm not in the healthcare industry, more doctors that I've come across and worked with than not have amazing intentions, have saved my life on a few occasions, and have certainly given me fantastic advice. So I'm pro-doctor.
Yeah.
But specific to the pain management side of things, I mean, I would tell my wife, like, once a month I had to go, when I was taking opioids, I would have to drive to a pain center, wait in a waiting room with a waiting room full of people that were waiting for the same thing, but it wasn't an enjoyable wait. And meet the doctor, not usually. Meet an intern or an associate, ask me a couple of quick questions, standing there, check off a few things, and then ask me if if I needed stronger pain medicine or not, and then send me on my way with my prescription. I would go to the pharmacy immediately, get it, and I got to the point where I was stockpiling opioids because I didn't know if this was going to change or end, and it became a real, I had to, when you asked me earlier what made me finally decide to stop,
Yeah.
I had to just sit there with a clear head and think about, what am I doing? I'm stockpiling opioids, I'm taking them constantly, I'm writing down every single day of the year, I'm writing down when I took the last one, because the one thing I've never wanted was to prematurely end my life. So I was turned into a bit of a chemist, a bit of a doctor, and I'm like, okay, I'm gonna go for dinner now with my family. I wanna make sure I'm not hurting too much, so I'm gonna take one about half hour before. Like, I was planning out my day around these drugs. And when I finally, with your help and the help of the MORE program, got off opioids and all pain medicine, I haven't taken a prescription medicine in 3.5 years. When I told the pain doctor the final visit, I'm off, I don't need anything from you, this is the final visit, not so much as a good job, not so much as a congratulation, and a little bit of a surprise, like, what do you mean? Like, it was like a, what do you mean?
Wow.
And I felt like, oh, you've lost a customer, I understand, but not even like a, well, that's wonderful. And so I think that side of things should probably change. There should be more encouragement. I think there should be more encouragement for that. I think what you're doing needs to get out there more. It needs to be more mainstream. I personally, I like listening to a lot of pods, and I see there's a lot of alternative medicines and supplements, and so I think we're kind of moving in that direction in terms of alternatives to just going to a pain doctor, getting a prescription, and going home and hoping. So I'm encouraged. I do think that people are being more aware of their body. There's a lot more documentaries, thanks to Dr. Gupta and others, that are talking about blue zones, talking about how to extend your life, how to live healthier. So I like all of those discussions, and I think it all fits nicely into what you're doing. So I'm positive. I think things are going in a good way, but we just need more people involved.
Yes, and I think that last point you made about if only somebody had given you the encouragement and the support to change the opioid use, and then, as you said, acknowledge the work that you were putting in to changing this very difficult habitual pattern, how much more motivated would you have been, and how much more empowered would you have felt?
6 months earlier, if they would have said, hey, just so you know, we have this new program, you can try it, it's not another pill, or give you those options, there would be a certain percentage of people that would say, great, because they're maybe on the fence of wanting to stop. There'd be a certain percentage that wouldn't want to do it, but there would be some people that would want to try it.
Yeah.
And for me, fortunately, I didn't need the encouragement. I'm lucky. I got lucky. I decided on my own it was time. But the fact that post stopping opioids and needing them, they weren't even saying that's wonderful news. I just found that surprising and probably more of a telling sign of the industry.
Yeah, let me just say, I mean, even more clearly, just to put a punch, I mean, Dan was part of a system that was prioritizing pills and procedures over patients.
Right.
I mean, that's the sad truth of it. It's starting to change, thankfully. And again, the idea that you collect the data, so you're not just putting these things out there and saying, hey, I think this is going to work. You did the hard work, Eric, of collecting that data. So there's nobody who shouldn't be listening to this at this point. This isn't conjecture anymore. There are real alternatives to helping people who are legitimately suffering. I mean, the one thing I think we can all agree on, those people in pain, they're in pain. That's their truth. But I think there's a lot more options for them than I think previously they ever thought possible.
Well, thank you. Thank you, Dr. Gupta, for outlining this hopeful vision for us. And thanks to these two leaders for their insights and inspiration. Thank you. And I think just a statement to end, pain is universal, but suffering doesn't have to be. And together we can build a new standard of care for people in recovery from addiction who are trying to reduce reliance on opioids and to help them to heal from pain and help people to reclaim their lives. And that's really the heart of the mindfulness-oriented recovery enhancement therapy program, the MORE program that I built. And if you want to learn more, go to moretherapy.com or come talk to me at booth 420 in the exhibition hall. But thanks to all of you for your work. You guys are doing life-saving work in the field.
Thank you, gentlemen. And ladies and gentlemen, please now join us in the exhibit hall, and we'll have our Passport to Prizes drawing at 4 o'clock. Thank you.